this paper, we are looking at 10 ICUs that initially were part of the ICRU, and a total of 3,212 patients were analyzed over a period of 3 years. Yeah. So the landscape, the ICU landscape in Uganda, interestingly, by 2020, we had about only 55 ICUs in the country, serving more than 45 million Ugandans of us. And most interestingly, 80% of these ICUs and beds were based in Kampala. So you imagine about my kinsmen in Rukunjiri who may need ICU care at the moment. But, well, I'm happy that this has changed, because in the room we have people as far as from Chisoro and Bwindi, which is our great catchment and progress that we are making as intensive care in Uganda. So undeniably, critical illness is a burden not only to us, but even to the higher income countries, and maybe even to the sub-Saharan Africa. This could be more. Yeah, where we belong, that's Uganda, as we assess the needs that we have for critical care. Yeah, we've worked in ICUs for long. We should be able to know this, that the critical care needs are going high, and the burden. Since from COVID-19, looking at the data, I don't think we've gone back, and I don't think we are going back any soon. So the ICRU, that's the Intensive Care Registry of Uganda, was established in 2021. A few sites, the champions, the Mulago 3D, and the others, Kampala Hospital, that were the pioneers. And yeah, from then, we've done progress in collection of valuable data entries. Like Herbert said, the data that is accessible to most clinicians, of course, with some regulations. Yeah, we have support. Thank you to Wellcome Trust and CCA, Dr. Rigi. We are grateful for this support. Thank you for supporting us that we can go on with such work in Uganda. So the design of this paper we're talking about, it was a prospective observation study. Like I already said, we had 10 ICUs at the moment, and the data analyzed was for the patients that were admitted in ICUs from January 2022 to December 2024. Only ICUs that started by then are whose data that we have in this report. So we had all patients coming to ICU, and there are some ICUs like Mbali and some other ICUs actually where we have the same space shared as HDU and ICU. All the patients that were admitted in such spaces were included in this report, except the patients that had the outcome missing were excluded. So ethically, thanks, Sharon. I know you're smiling. At times it doesn't come easily, but we are grateful. We get our approval from Makerere University School of Medical Science. And we are Uganda National Council of Science and Technology approved as well. So this report focuses on the ICU demographics, the comorbidities, the daily management of our patients, as we're going to see, and the primary endpoint we considered in this report was the ICU mortality, but we also have analysis coming through that included the duration of ventilation, length of ICU stay for these patients, and discharge destinations where these patients after leaving the ICUs were going. Then also we looked at the instances of readmission in that time frame. So clearly, the ICU registry data clearly shows that we have a fairly young population of about 30, average 38 years. Yeah, and as you can see, this translates to having a bigger population of about 56.8 patients admitted to ICUs without comorbidities. Definitely because we have a fairly young population in ICUs. Yeah, this is a good thing, definitely. Maybe when you look at the mortality we had, this could be worse if we had the aged patients coming to the ICU. So also interestingly, we noted that we had quite a big patients coming to ICU from theaters at 48%, which is quite big, almost half of the population coming to ICU. So, we had the admissions sources of where these patients that came to ICU, where were they coming from? We had ICU OHDU of other we had other hospitals. We had patients that were admitted on wards and maybe they deteriorated and ended up coming to ICU. And we have quite a number of patients that came straight from the emergency department. By the time they showed up at emergency, their conditions warranted them to have ICU care. Then, yeah, like previously said, we still have a very big chunk coming from operating theaters. So, yeah, partly we're going to see why we have most of them coming from OR, and like Felix from Bara highlighted, I think the road situation in our country where we have a lot of accidents. That's why most of these patients after surgeries, they are not fit to be monitored either on ward or any other source. The best place we take them to is ICU. So we looked at, on admission, we looked at physiological, acute physiological and chronic health assessment. And at least, like, importantly to note, we had the biggest percentage falling under moderate, showing that clearly on admission, the population who had, most of them were sicker by the time they got to ICU. So we saw, overall, we saw people coming to theater, people from other hospitals, like we already saw emergency units and wards, and we had quite a number of HDU ICU transfers. And for the projects that I've worked with so far in ICRU, the discharge destination speaks importantly to me. I'll say why in a bit. So we realized most of our patients, 53% from ICU, they were getting towards. An important question to ask here, by the time you're exhibiting that patient for the next patient and sending them towards, is it the right place where they should be? And we had quite a number of patients as well. About 37% of the patient survivors leaving ICU go to HDU. Maybe still this percentage isn't that big because in our country, especially for the public, we still have limited spaces in the HDUs. Then we had other patients preferred to be sent to other hospitals for anything. We've seen there is a project that Brian is going to talk about, which is out-of-pocket expenditure. We've had scenarios where someone is in ICUX, no matter what is going through the progress in treatment, but because of the cost and logistics, they opt to go to other ICU. Then we had a small percentage being transferred to another ICU. So what sense do we make out of this data, that we have a relatively young population? in this cohort of the data that was analyzed, averagely 38 years, like I said, maybe the mortality would have been even worse if we had an aged population like we see in the developed countries. So, the overall mortality was at around 29.7, which is comparable to other countries or health systems in the region, that's Ethiopia and Kenya, but of course much bigger to what we see in the high-income countries. So, yeah, like we already said, admission source mainly was out of theater, directly from theater, and like, yeah, all other developed countries, I think our problems cut across. We share the neighborhood and we share the systems and we share the problems, where we have quite a poor road system, transport system that exposes us to accidents. Then also what we make sense of the data we analyzed, surprisingly we had quite a number of patients going through the renal replacement therapy. Yeah, of course we cannot, this was out of 10 ICUs, we can't know whether this was public or private, and yeah, maybe we could try to do retrospective how many public facilities by then had the dialysis centers. So, this is so also we look at the nurse bed ratio. I will not reiterate what Esther already said. It speaks for itself. Compared, which is a ratio on average 1 to 4, one nurse looking at very sick 4 patients. Imagine that night duty. Compared to the high ends, like where Ruth works, where we have 1 patient, 1 bed. Yeah. And also we looked at the level of cadres that work and take care of these patients. And most of them, at least only 3% by then, had had critical care medicine training at a postgraduate level. That's how, yeah, I don't know, maybe you would wonder if they've not had this training, who are these people taking of us when we are in ICUs? Yeah, something to think about. So, yeah, 80% of these ICUs are in Kampala. Much as we have Innocent and Dr. Sharot and Jonathan in the room, I don't think it has changed that much, but we believe we shall get there through advocacy and if we have to use this data to push it further. Then one interesting thing why I said this speaks right to me, we had a 50% inter-IC transfer mortality. Like imagine a patient, they're not comfortable, or for any reason they have to leave Lacho and they are coming to Mulago. Think of our systems that are involved in the transfer process. Those delays, the facilities we use. So it's no wonder that we had a 53% mortality of these patients that were transferred. Yeah, someone was advocating for training at every facility. Maybe this would be one of the things that we would use if a clinician at the other facility could be able to manage and reduce the instances that we need to move these patients to other ICUs, considering that the problems we have as a system. In conclusion, there had been other studies that were done about the demographics, the case mix of the ICU patients, one by Dr. Patience Atumanya, Professor Pizera. But why this stood out, this was a Mal's center. Most of them were short period and were single center studies compared to the ICRU epidemiology paper that covered up to 10 ICs over a period of 3 years, which is good enough to get the right picture that we are seeing here. Yeah, we have a fairly young population and most of our patients are admitted from OR. Yeah, I stop here and wait for any questions. Thank you.
Thank you, Alice, for the wonderful presentation. Do we have questions? Okay. Fast forward to next presentation.